Yeah. Okay, Dr. Dilakshmi, when you are ready, we will start.
Doctor, can you see me?
Yes, yes, I can see you. Let me just have a look. Your camera is, yeah, I can see you. Yeah, thank you very much. Yes, please
I
start.
cannot see my. Okay, all right.
I can see you. Yeah, I can see you. So how are you doing today?
I'm okay. I'm working, but I'm okay.
Okay, okay. So which center, Dr. Bilashini, you are?
Actually from Malaysia, but I sat for the exam in Singapore because I didn't get a place in Malaysia.
Mm,
So
okay.
then RCPCH emailed me asking, there's a place in Singapore. Do I want to go? So I just said yes. So that's how I was there.
Okay. Okay. So Singapore station, just let us know what was your first station.
So my first station was history taking. The scenario was, I think, a 10 years old boy. He's already got underlying Crohn's disease. And the issue now is that he came in with abdominal pain, diarrhea, and weight loss for the past 1 week.
Okay.
So I had to talk to the mother, who was actually a real patient's mother. It was not a it was not a fellow doctor. It was actually a real mother. So
Okay.
I had to explore, besides acute flare of the IBD, I had to explore if this was something else, and was it food poisoning or anything of that sort. So as I took more history, I actually realized that compliance was an issue, and they defaulted a few follow-ups with the hospital. So then after that, the discussion went on to what I think it might be. So then I said it's probably a flare, and then the causes of the flare and everything. And then the discussion was mainly on Crohn's disease. And then he asked me about management as well. How would I patient? And I mentioned everything. Then specifically steroids to induce remission, because this is not a new case. And finally, if he asked me if everything does not work, then what would you do? Then I said biologics. And he asked me any example of biologics that I know. Then I said infliximab. Then the examiner was happy. But another issue with that family was social factor, finances, and this was a teenager. So the patient himself was not compliant. Then one question they asked me was, how would I ensure compliance in a teenager?
Okay.
So then I said, support group, fellow peers, psychosocial support, things like that. And I actually finished a bit early, and the examiner said, you know what, that's all. I don't have any more questions. So
it was easy station for you. I mean, you did not stuck in any question, or you did not find it difficult.
no,
What
I think
age of the child? Sorry, what was the age of the child?
13. I think 13. He was teenager.
Teenager, 13 years. And complaint was diarrhea?
Abdominal pain, weight loss for
Okay.
1 week.
Loose stool, abdominal pain. So examiner just wanted to ask about the infliximab, right? The biological agent.
Yes.
Only this one. Surgery,
Yes.
surgical treatment, multidisciplinary team.
Yeah. Investigation.
Okay, investigation. Okay, so it was easygoing station, right? And you got how much mark here?
I got full.
Full. Very good. Very good. Okay, so shall we move? Anyone, if you have any question, please open mic and you can ask Dr. Vilashini. Today is not a teaching session. It is actually for you guys, that what question examiner asks in the station. Okay, what was the second station, Dr. Vilashini? Then anyone can ask her question. Okay. Yes.
My second station was video station, first video. So it was a opening statement was 4-year-old boy brought to the hospital with underlying developmental delay. Can I write no history? Someone's asking. Yeah, I did. Yes, but I told the mother while you're talking, I'm just going to write some stuff down. And mother agreed.
Okay.
So the second station was video station, 4-year-old boy with underlying developmental delay. So the video was actually a young boy sitting on a stretcher. His one hand was on the railing. So from the video itself, it's pretty obvious that developmentally he's a little delayed. And what was very obvious was self-mutilating behavior. His hand, he kept hitting his head. But actually, there was a misunderstanding. I got this one wrong. It looked like he was hitting his head. Nobody else was in the video, only the child. And that's all about. And he was moving forward a little bit. So then time was done and the examiner asked me what I saw. So I said, it was a 4-year-old boy in hospital setting and not in distress. And I said there was some mutilating behavior whereby he's hitting his head. And I stopped. So the examiner asked me, what about the posture? Actually, I really didn't see anything in the posture, but I did tell her that, there is some forward movement that is likely drop attacks. Then she's like, okay. So
it was actually not self-mutilation, it was seizure, right? Convulsion.
It was jerking of the hand.
So it was jerking of the hand. It is like convulsion, right? Focal seizure.
Yes. So no. Seizure. Yeah. Seizure.
So you got it wrong. You said self-mutilation.
But when I said drop attack, I think I was okay. That's why she didn't clear fail me.
Okay.
So then the discussion on to seizure investigations, management, and genetic workup. I think that's about it. But I lost a bit of mark because she said she had to prompt me about the posture. That's when I understood that this was actually a drop attack.
So she cut your mark because he had to prompt you. Okay, but it was actually drop attack or focal seizure, which was in
I don't. Until today, I don't know which it was.
Okay. So yeah, hitting the head is actually not self-mutilation. It is hitting the head. Yeah, possible. Self-mutilation possible. So it was actually a focal seizure. Which type of seizure it is? Let me think. Not myoclonus. Myoclonus is shock-like, right? Shock-like movement. It is myoclonus.
But I was speaking to one of the examiners after exam. They were saying as long as you mentioned the word seizure, they didn't really care what was the type, as long as pick up seizure should be okay. But I think among all my friends, everybody who sat for that exam on that day, later when we were talking to because we all have to go in for a meeting with the head examiner after exam. So one of the biggest complaint was the video was not obvious of a drop attack, and everybody thought it was a self-mutilating behavior, and some even said Leach-Nyhan syndrome and like that. So
Leach-Nyhan, then there are other syndrome now we read in our class, like some neurometabolic Rett syndrome. But if it is a boy, Rett syndrome is very rare in boy. So it's X-linked dominant. So yeah, Leach-Nyhan, you can say autism as well. Autism has like this kind of hitting tendency, behavioral problem. Yes. So they did not make you clear fail because you said seizure actually. Okay, very good. Okay. Next
Yes.
station, next video. Anyone has any question, please feel free to ask Dr. Vilashini, okay? If you don't understand any point. Okay, next video station, video 2.
So video 2 was clinical, it was a doctor doing recipe clinical examination on the video. So what we could hear was the findings like the air entry, crepitations and all that. Percussion. So also somehow I got this one wrong. This is my lowest station actually. So one side the air entry was one side the air entry was loud and the other side the air entry was normal. But
So
I
they gave you the breath sound, no? They gave you the breath sound, and one side it was low. Okay.
One side was low, one side was normal. But I got it the other way. The normal side I said was increase and the low side I said was normal.
Because of the exam stress.
So when I was telling the examiner what I found, so because my findings was already opposite, so he's like, can I just clarify with you, your findings are which side? So I said right side. He's like, okay. And then he told me, assuming that the findings are on the left side, how would you investigate this patient? And he said, assuming this is pneumonia, how would you investigate? So I think I got very few marks for the findings, but the discussion was okay because the discussion was about pneumonia. So the investigation for pneumonia, and he said, what are the complications? So then I said he could go into pneumothorax, post-infectious bronchiolitis obliterans, empyema and all that. So then he was okay. Then I told him the management. Then he asked me, how would I look out for complications? So I said, if pneumothorax, then I would need to look out for saturation, daily saturation monitoring, or suddenly the child will become tachypneic. And if this was abscess or empyema, then there will be a temperature, fever, patient will be unwell. So for discussion part, he gave me marks, but I think the findings per se was bad.
I mean, you actually, examiner understood that you are nervous. You are nervous now. You are in stress, because otherwise he understood there is a reduced breath sound. That means you passed. But the examiner took it lightly. He did not took it seriously because you were very nervous. And as your first video, you could not do well. So that is the thing you thought, oh my God, I did not do. Never ever do that. Please, my advice is, if your one station is wrong, leave it. Think like, okay, I will do good in this station, I will do better in this station. Because if you continuously thinking about previous station, then your next station, you did mistake in this station because you were so much sad about your previous station. Am I right?
Correct.
Dr. Vilashini, at this point, I have one little question or query, whatever.
Sure.
At first, congratulations for your brilliant success. You are really you are now a matter of inspiration to all of us, because as far as I know, Singapore was always considered to be a difficult center, and you have come across with flying colors. So congratulations, big congratulations to you. And now regarding the video station, on the second video, did you get to hear the breath sound, or someone was like there to tell you that this one is this or this one is that?
Breath sounds. They played out the percussion note, and the crepitations also was heard. And vocal.
Did you receive any opening statement or just an audio file playing along?
There was an opening statement that said it's a 10-year-old girl with 1 week history of fever and cough, given ampicillin, and the symptoms did not resolve. That was the statement.
Okay. Then the audio file was played.
Yes.
Was it being played for like 3 minutes at a stretch?
Yes. So somebody with me, I never touched the mouse. Somebody was there with me. When the video ended, they just kept replaying it for me.
Okay. Thank you, Dr. Vilasini. And regarding the first video where it was a confusing situation, like whether it was self-mutilation or a drop scissor, did you receive any opening statement in that particular station for the video
Yes,
one?
yes,
You
it
could
was a
kindly mention.
they said it was it was written as 4-year-old boy with developmental delay.
Okay. Thank you, doctor. Congratulations and enjoy.
Thank you.
Okay, shall we move to next station? If anyone has any question, please ask, okay? Yeah, next station is what, doctor?
So my next station was developmental station, and the opening was it's a 4-year-old boy mother brought in because she's concerned regarding his walking. So I understood this was a gross motor station. So this station had a role player. Yeah, had a role player. And so I took history from the role player. That was fairly smooth. It's not an issue, not a problem. But as I took history, I realized there was no developmental regression. Just over time, the boy was having difficulty going up the stairs and unsteady gait and with frequent falls. But other aspect of development was all normal. So then history was fairly smooth. Then we moved on to examination. The role player left. I didn't have a real patient, so I was talking to the examiner. So I asked that I would do. The child was not dysmorphic, no hearing aid or no walking aid, absolutely nothing. It was a very cheerful child. So then I asked her so she told me when I walked in, she said the child is sitting at a table coloring. So I said, can the child stand up for me? Then she said, okay, child is standing. So I asked her when the child stood up, was there any difficulty? I was actually particularly looking for Gowers. Was there any difficulty? Did the child climb on himself? She said, no, he got up very fast, very easily. So then when I asked her about the gait, then she said, she actually demonstrated the gait for me with her hands, and it was
very good.
so
That demonstrated very good. Yeah.
Yeah, because she refused. I think she didn't want to tell me it's a high stepping gait.
Okay.
So,
okay.
Yeah. So this was actually a Shakumeri case, Shakumeri tooth.
Charcot-Marie tooth in development. Very good. Very good. My God. Everyone, please note it down. Any syndrome, any condition that causes developmental delay can come in exam, and you have to understand the situation. Otherwise, your management plan will be difficult. If you don't know what is the station, your management plan will be difficult. Okay. So Charcot-Marie tooth syndrome never came in development. Phenylketonuria never came in development. Now they are giving. So the exam question is continuously changing for last 1 year. So it's very, very now high time to study hard. Okay. And fail is very easy in clinical exam. Very easy fail. You cannot imagine. In the blink of an eye, you will see fail. So work hard. Very important. Yes, Dr. Vilasini, please continue.
So she asked me what am I thinking? What is the most likely diagnosis? So I said isolated gross motor delay, likely because of Shakumeri tooth. Then she's like, what are the differential you have? At this point, I actually forgot the vincristine toxicity and B12 and all that. And I said, if this was an acute case, I would think of Guillain-Barré and bilateral polio. But then the examiner said, yeah, but the history says 1 year. I said, yeah, then unlikely. Then she moved on to investigation, management. Management is where she wanted to hear a lot more. She wanted to hear the word genetics. She asked me, how would I advise the mother in aspect to if she wants to have another child? So then I told her she needs genetic counseling because Shakumeri tooth runs in the family. It's autosomal recessive, and a lot of management. She asked me who would I refer to. So then it was all the necessary, and she asked me if occupational therapy is needed here. I said I need orthotics team to give him orthosis to help with the foot drop. But occupational therapy, I actually said don't need. I said need physiotherapy, rehab, and orthotics. But I think she cut marks for me here because actually the feedback that she gave me was I didn't know what the role of occupational therapy here is. So out of 12 marks, I actually got 10 marks. I think it's because of the OT, occupational therapy.
Why?
Otherwise,
What did you say? OT does. What OT does fine motor and OT does modification of home modification. Why he will cut mark? You said right. The small muscle, fine motor. Actually, this is a gross motor station. No? That's why examiner did not want to hear about fine motor.
I said don't need occupational therapy. And
No, they need. Why not need? Why you said this line? Why don't say don't need? Don't say this. You can stop. You can omit this point if you feel that examiner does not want about fine motor. But this child need, oh my God, Vilashini. This child needs home modification, right? CMTD, high stepping gait. He will fall.
Yep.
Repeatedly, he will fall. So who will do home modification?
OT, yes.
You could easily get 2 more marks.
Because I forgot about home modification because I know OT is fine motor. So
It's okay. It's okay. Now you passed. It's okay. But OT people, they do home modification. Okay. So it's very important for Charcot Marie-Tooth.
yes, okay.
All right. Next.
Next was my 4 clinical stations.
Okay. What was that for?
So my first one was others. This was one of my toughest. So I walked in. It was a 16-year-old boy, very well-looking boy, very well English-speaking boy who was sitting up on the stretcher, and my examined this patient's face.
What is the age of this child? Sorry, face
16.
examination. Teen years. I mean 13, 14.
16.
Oh, face examination. What was that in face?
So at one glance, absolutely nothing. There was no drooping, nothing. So I spoke to him. I said, can I examine your face? He's like, yeah, sure. I was like, okay. So I started off with the facial nerve first, cranial nerve 7. So I asked him to wrinkle his forehead. There was bilaterally, there was no wrinkling of forehead. I asked him to close his eyes and I tried to open. I cannot open. His eyelids were actually quite strong. And then when I asked him to smile, it was very weird. He couldn't smile, like his whole face was restricted and there was loss of nasolabial fold bilaterally. Then, so it was a very mixed picture because there is bilateral cranial nerve 7 involvement, but the eyes he could shut close. And then that was 7. Then I proceeded to check for ophthalmoplegia. There was no ophthalmoplegia. So at this point, I was a bit lost. So I looked at the examiner. Then the examiner was like, it's okay, just proceed. So I proceeded with cranial nerve 8. On the right side, he couldn't hear. He really couldn't hear on the right side. So, and I did sensate, before I did cranial nerve 8, I checked trigeminal nerve first. The entire right side, there was loss of sensation. He cannot feel. So then I did cranial nerve 8, the right side also, he cannot hear anything. So the examiner then, and there was also a left mandible swelling, quite obvious, quite big and not tender. So I didn't know what I was doing at this point. Then the examiner stopped me. She's like, okay, so tell me your findings. So I told her I feel bilateral cranial nerve 7 is involved. Cranial nerve 5 is also involved because there is no sensation, and cranial nerve 8 is involved. However, there is no ophthalmoplegia. So because cranial nerve 7, 5, 7, 8 is involved, I feel this is likely originating from the pons. She's like, okay. So she's like, what do you think could be the issue? So I said maybe any tumor in the pons or any infection affecting the pons or any bleeding to the pons. She's like, okay. So then she asked me, how would you investigate? I said, I would need brain imaging. Specifically, I would need to do a MRI brain. Then she said, okay, besides MRI brain, what else would you do? The bell rang at this point. Then I couldn't answer. So I got 5 for this patient.
It was upper motor neuron lesion, right? Facial nerve.
Yes, upper motor. So she asked me, another question she asked me was, what else would you do to localize the lesion? Then I said full neurology to see if this is upper motor neuron or lower motor neuron. She was happy with that answer. Then only she proceeded to ask me the investigation, which I didn't have enough time for.
So any instrument given to you for this, like cotton bud, anything, cotton or pin or anything?
They put everything on the table. Whatever. Yeah. So I have to pick myself. Whatever everything was there.
Okay, so this is very important that instruments will be on the table. So whatever you want to do, you can take it.
So I used cotton swab. I think for this patient, I only use the cotton swab. Yeah, because
cotton is in facial nerve for this conjunctive, right? For
trigeminal.
Trigeminal, yeah, like that. Trigeminal, but okay, trigeminal, not for facial. Facial we do not use. For facial, what we use? Nothing. Facial is the motor nerve, nothing. Yeah. Okay, next session.
So that session was very stressful.
Yeah, it was. Exam is stressful. It was, yeah.
So
I would like to ask a question, please. First of all, congratulations, Dr. Vilashini. Actually, I wanted to ask that you said there was a profound hearing loss on the right side. So did you use the tuning fork or whisper test?
No, I just did that. Whether can he hear? He said no. Because I don't think I would have time.
But he was replying to you, right? He was following your commands.
Yes, the other side, the hearing was intact.
Okay.
It was the border tympani branch of the facial nerve. If this is involved, then if you do a small movement, he will have hyperacusis. Actually, hearing loss is not the feature. It is hyperacusis. That is the feature. What you did, Dr. Vilashini, that is the test for hyperacusis, not for hearing loss.
Okay, thank you.
But you did, there may be hearing loss. You know why? Because concomitant involvement of the cranial nerve 8. Possible, because if it is tumor in the pons, hearing loss will be possible. Because 7, 8 nerve, auditory, like, olfactory, optic, oculomotor, like nerves are related with each other. Vestibulocochlear, they are related with each other. But the test for facial nerve is not hearing loss. It is for hyperacusis. Anyway, any other question?
Dr. Vilashini, what about that mandibular swelling? You mentioned some swelling.
Yeah, so I just told her the findings was the mandibular swelling, but my diagnosis had nothing to do with the mandibular swelling. The feedback she gave me was I was able to diagnose the cranial nerve 7, cranial nerve 8, and the cranial nerve 5, and the mandibular swelling. But I couldn't correlate everything together.
Thank you.
Okay, very good. So mandibular swelling, maybe some injury or something. Is that there is bruise or no?
No bruises and not tender.
Is it some Caffey's disease like hyperostosis, Caffey's disease? No. Caffey's disease has mandibular swelling, right?
Yeah, maybe.
Okay. Next, shall we move next? Yeah.
Yeah. So my next was a neuro station. A 13-year-old boy examined the lower limbs. So I got the patient to walk for me, and I wasn't too sure what gait that was. And when I asked him to tiptoe, he was very unstable. When I asked him to run, also he was very unstable. So then once I proceeded to examine the child, it was a upper motor neuron lesion actually. It was upper motor neuron. So because this was upper motor neuron, I quickly did a head examination. There was no VP shunt. And then I quickly asked the examiner if I have time if I can just quickly proceed to upper limbs, which I could. I only checked tone and reflexes, and the time rang and the bell rang. So my differential was it was actually spastic diplegic CP. So I told her spastic diplegic CP. Then she said, what could be the causes? I say causes can be divided into prenatal, antenatal, and postnatal. And actually, she didn't even let me go on. I just said prenatal, postnatal, antenatal. She's like, okay, fine. Then she
she knew that you know this. When examiner, I told you na, that examiner will stop you if he know that you know. Okay?
Yeah. So then I think she asked me she didn't ask investigation. There's no investigation. She asked me how would I manage this patient. I told her everything. Then they were like, okay, that's all. And literally stood there looking at them for like 30 to 45 seconds. So yeah, that's all actually. That station I got full marks.
Very good. Next station. Any question? Please feel free to ask Dr. Vilashini. Okay, I'm not speaking anything today. Yes.
Hello. Hi, Vilashini. Congratulations, first of all. What was the feedback for the station?
Feedback. She is asking. You
I'm
remember?
not sure. No, I don't. I can check right now. But
okay, I will check your mark sheet. I have. Okay. I will check for you. Okay, you proceed to the third station. I'm telling you, doctor, what the doctor said.
Okay, so third station was cardio. It was the cardiovascular station, and this was a boy. This was I think it was 12 or 13-year-old boy, but he was small for his age. It was very obvious he was small for his age. He was fully dressed. So what I did was I did the cardiovascular examination. I actually checked his peripheries first, and then the brachial radial pulses, his face, and then only I asked him to take off his shirt.
What was the station? CVS, right?
Cardiovascular, yeah. So when I took off the t-shirt, there was a median sternotomy scar, very well, meaning it's old. This boy was pink under room air. He was very pink, and there was no clubbing. But there's a median sternotomy scar. And until now, I feel like I didn't see any other scar. There was no lateral thoracotomy scar, but the feedback I got was that I missed the lateral thoracotomy scar.
Oh, because it was very healed, and it can be easily missed if you do not go close and see the info. And you have to go very close to the child,
Okay. So he was not in failure, not in distress. So the murmur was great. There was no thrill. So the murmur was actually a right ventricular outflow tract murmur radiating to the back, and grade 3 was ejection systolic. So that's what I told them. Actually, I presented one by one. I said there's no radial delay. The boy looks small for his age. Then they stopped me. They said, can you just go positive fine? So I said he's under room air, there's no clubbing, and there's a right ventricular outflow tract murmur, loudest at left second intercostal space, and he is radiating to the back, and there is no failure signs. So I said, this could be a underlying. Okay, first I said likely this could be an underlying acyanotic heart disease with a pulmonary stenosis murmur. So she asked me, why do you say this is acyanotic? I said, because patient is pink under room air and there is no clubbing. However, having said that, this could have been a cyanotic heart disease, which is repaired and he's no more clubbed. Maybe clubbing has reversed and he's now pink under room air. So they're like, okay. Then they asked me, what murmur is that? I said, likely it's a pulmonary stenosis murmur. They said, okay. Then they asked me, they actually did not ask me investigation. She asked me differential diagnosis. She said, if this is not a tetralogy of Fallot, what else could it be? Okay. So I said it could be a pulmonary atresia with intact ventricular septum, or pulmonary atresia with a VSD, or or previously pulmonary stenosis repaired but failed. And then they're like, what else? Then I stopped for a while. I couldn't think of any more. Then when I paused for 3 seconds, they said, okay, never mind. Then they moved on.
So it was actually TOF with RVOT murmur, right? TOF repaired.
Actually, that's what I thought. But in my mark sheet, they wrote that as PAVSD, PAIVS or PAVSD. That's what is written in my mark sheet as the patient's diagnosis.
Okay. So it is VSD with PS, right? Yeah, it can be VSD with PS, possible. It's not like every time it will be TOF, not like that. Okay. Any
No,
other?
pulmonary atresia with VSD. Oh.
Okay. Okay.
And
your
then
clinical, wait, just I found your mark sheet. So the clinical station, first one, diagnosed bilateral 7 nerve palsy, diagnosed swelling left cheek. So you diagnosed easily. 5 nerve sensory problem, 8th nerve problem. So you diagnosed correctly. So there are multiple problem in this child. Actually, it was a case of tumor, okay? And the tumor is also on the mandible. Some skeletal tumor, okay? And needed some prompting during discussion, diagnosed SOL and bleeding. So very good. You did good marks and the examiner was happy actually. This was positive comment. So it was a case of some tumor that was affecting multiple cranial nerve. So guys, write it down, please, or everyone, that multiple cranial nerve palsy will come in exam, okay? Now the second station CVS, they said residual PS PR, as you said, residual PS or PR, conduct. This is conduct stenosis. I mean, conduit stenosis, conduit. They do it repeat. Conduit stenosis. The case was PA VSD with patch, okay? Some patch done. So VSD patch closer. And only missed left thoracotomy scar, pre-auricular skin tag. So this was a case of pre-auricular skin tag. That means this is a syndromic child, okay? Pre-auricular skin tag and you miss the lateral thoracotomy scar. So what we learned from this station that you have to go very close in CVS or abdomen station to see is there any residual scar, very old scar, healed scar. It will be flat with the skin. You will not find it. And the other general examination is very important. Pre-auricular skin tag, vertebral problem, neck problem, you know, scar behind the neck, scar behind the ear. It's very important to look. It is live exam. It is not an online exam. So you have to look the patient very carefully. Okay. All right. And the third comment for your, no comment, third station, they say tone increase bilaterally, power 4+, reflex, neurostations, spastic diplegia, reflex increase, you said. It is spastic diplegia, detected the sign and had differentiated. So there is no comment, full mark. And okay, fourth station we did not go. Needed prompting regards to assessing the DD. Clean management plan. So you did very well. Clear management plan, you said, and needed prompting. So prompting means what, guys? Prompting means examiner is what else, and this is called prompting. So you should not give any chance to examiner to prompt you. Okay. Yeah. So tell Dr. Vilashini, someone is asking you some question in the what books you used.
You examined fully, then started talking or stating your findings to exam. Okay, so I didn't do running commentary. I examined fully and then only I started talking because I needed time to put things together. From whom you took sponsorship? I don't know what's a sponsorship.
Sponsorship means your teacher, that name you gave. Who is the trainer of you?
One of my specialists. I did tell her that I'm putting her name and she was okay. And which books I read? The Malaysian book, Mark BT. There's another book, Rebecca, for communication. And really important topics, I read Wayne Harris as well.
Very good.
Okay.
anyone can become your sponsor who has MD passed. I think yes, anyone can become your sponsor who has degree.
Okay. What is passing criteria? I think the passing mark is 64, Dr. Tamanna. I'm not too sure what's the passing mark.
Yes, 82 is the total mark. 82 and 64 is the passing mark. Wait, let me check just 64. Right, Dr. Shinash? Passing mark is 64, right? Dr. Nada, Dr. Shinash?
In Jeddah, it was 62, ma'am. I don't know about other centers.
Yes,
They
yes.
said-
Face-to-face is now 62. But in online, I think, no, it is reverse. Face-to-face 64. Online, it was 62. Okay. Okay, 62 or 64, like that. There were two marking, before online and now face-to-face, okay? And if you get 52 or less, you cannot give exam for 1 year. This is the lowest mark, 52. So be very careful unless you are prepared well. Okay, don't think about trying to give exam because it will be stop you to give exam for 1 year further. Okay, yes, fourth station was?
No, my cardiovascular, my last station was very odd. She
Sorry.
camp
Yes.
is going for a camp.
Some mics are mute, doctor. Some mics are mute. Please mute your mic. Yeah, sorry. Yeah.
If this patient was going for camp, what advice would you give? So I said avoid dehydration and few things I kept going, but they were not happy. So then finally she asked me, like, what would you advise the people who are organizing the camp? I said, he has to be careful with strenuous exercise. And then she asked me, if the patient collapses on site, then what advice would you give the camp organizers? Then the bell rang. I couldn't answer. I don't know the answer also, but the bell rang and I didn't answer that question.
Okay.
Then,
So it was cardiac station. It was fourth one.
yeah.
So you get two cardiac station.
No. This is the third cardiac, the pulmonary stenosis. My next one is abdomen.
Okay, abdomen. What is the age of the child?
So this child was 7 or 8 years old. He
Hmm.
was well grown for his age and not dysmorphic. He was fine. There was no peripherally, there was no jaundice, but his eyes, I thought, had a bit of tinge of jaundice. And so I said that, but when I examined his abdomen, it was very obvious that he had a hepatomegaly at least 4 finger breadth below the costal margin. There was no spleen. There was no surgical scars. So I told the examiner that I found a tinge of jaundice and there is hepatomegaly. She was happy that I found hepatomegaly. Then she asked me what's the differential diagnosis. I said this could be a chronic hemolysis, could be thalassemia, could be hereditary sickle cell hereditary spherocytosis. I said could be sickle cell, but at this age, I would expect some splenectomy scar or autosplenectomy, but very unlikely. Then she said, if this is not this is not hemolysis, what else could it be? So then I had a mnemonic memorized for isolated hepatomegaly. So I was going one by one. So one of it was leukemia. So when I said that, I think she felt like I was deranging from the question. So then she asked me, what if I told you that this patient had hypoglycemia during neonatal period? Then I said, then I would think of glycogen storage disease. Then she asked me the management for glycogen storage disease. Then she only asked me management. So I told her the management and I went on to tell her about how I need to advise the mother regarding seizures, signs and symptoms of And after that, she was happy and the bell also rang. Then that's it. This one, I think I got 7 marks. I lost 1 because she had to prompt me about the glycogen storage disease.
Okay. So only isolated hepatomegaly you did not understand. So, okay. Anything else in this 4th station? So there was no comment in abdomen station, only needed prompting. That's all. Prompting means the glycogen storage prompting. You got She got very good mark in this. So, okay, Dr. Vilashini, we finished. So your stations finished, Dr. Vilashini, I think. History, communication. Yeah, communication now.
Okay, so my first communication was anaphylaxis. It was a teenager brought in last night for anaphylactic reaction. The parents are very concerned because she didn't carry her EpiPen. She went to a birthday party, had some cake, went into an anaphylaxis, and she didn't have her EpiPen with her. And she has had an episode of anaphylaxis last year. And that's when she was given the EpiPen. So they said, so I thought I was talking to parents. Then they was like, parents are very concerned and they want you to talk to her, to Sarah. I think she was the old Sarah. So I was talking to a teenager. So I went in, I started off by saying
you forgot who are you talking with?
No, only the last statement says that I have to talk to Sarah. Because initially everything was the parents are very concerned and this and that. Then down there is parents would like you to talk to Sarah.
See, so that's why reading the statement is very important. You have to know whom you are talking with, right? In our class, we discussed this thing yesterday, that whom you are talking. Is it a mother? Is it a child? Is it a nurse? Right, yeah.
So she was not a difficult teenager. So I started out by saying our conversation is confidential and all that. And so I had to dig out why she didn't carry her EpiPen with her and why she didn't use it. Then she said, "Doctor, do I really need to carry my EpiPen with me?" I said, yes, and yes, because of this and this can be life-threatening, that. Then she said, "Doctor, how I know that I'm going into anaphylaxis?" So I had to talk about the signs and symptoms of anaphylaxis. Itchiness, difficult to breathe, and that. Then she said, okay. Then it was going relatively smoothly. Then when I asked her any other problem, but this was like towards the end, I think I only had about 2 or 3 minutes left. And that's when she told me that, "Oh, doctor, actually, I don't know how to use this EpiPen." But I had no time to teach her at that point because I'm already at my 3rd minute bell already rung. So I told her that, no problem, I will definitely arrange another meeting with you and teach you how to use the EpiPen. And then I summarized, and that's it. I think I got full marks. I think I did.
You did not ask that, do you know how to use EpiPen? You did not ask the teenager this question before?
When I asked her any reason why you don't want to carry the EpiPen, she had other agendas.
Okay.
She said, "I really need to carry, so do I?" I didn't directly ask her, "Do you know how to use?" And she had other questions for me. She asked me, "Am I allergic to other nuts?" Because she's allergic to peanuts. So she asked me, "Am I other nuts?" So then I said, "No, you're only allergic to peanuts, but it wouldn't hurt for you to get a allergic testing towards the other nuts as well." So towards the end, when she said that, that's when I also panicked. I'm like, "Oh my God, did I deter from the agenda?" So, but I did tell her. Then I gave her brochures, I summarized, and yeah.
Okay. So any question, guys, or should we move to next? Okay, next what?
Okay, my next one was very tricky. This was I think about 12, no, I think a teenager also, 15, around teenager boy who was referred to me from GP for diabetes type 2 because this boy is obese. His BMI was more than 99 centile, and however, his BP was normal. His fasting blood sugar was high. I think it was 7 point something, and his HbA1c was 8.1%. But his cholesterol was normal, BP was normal. So it's just the glucose. So they wrote there, GP has diagnosed as diabetes mellitus type 2. Please talk to the mother. But when I went in the station, it turned out to be an angry mother.
Okay, why angry?
Yes, so the mother was very upset that the GP had gone and did all these blood tests without asking her permission. So I had to apologize on behalf of the GP and said, I cannot speak for him, but this was not right. I apologize on his behalf, but it's already been done and I'm here to talk to you about it. So she asked me, I think the whole agenda was, so I told her I wouldn't diagnose this as diabetes as well. I think this is a pre-diabetic condition. I didn't use the word impaired fasting. I said this is a pre-diabetic condition, and then I went on to, I said his bone marrow, his body mass index, whereby we take his weight and height, and is actually quite high, and actually we would consider this as obese. Then she said, doctor, I don't like that word. You can just use overweight. I was like, okay.
Yes. Be very careful, huh? In UK, they do not like it. You have to say in a polite way that weight is more than the expected. You cannot say obese. Like, buffalo hump. You cannot say buffalo hump. If mother moon face, buffalo hump, we do not say this thing now, because in UK they are very sensitive to wording, Yeah, proceed. So it was not a case of diabetes type 2. It was pre-diabetic, right?
So I said, his weight is so high, and actually medically we call this obese. So that's when she said, doctor, I don't like that word. I said, okay, okay, sorry. Then I went on to tell her about diet and exercise, but she made it very difficult for me. She said, doctor, he won't exercise, and I cannot control his food. I'm like, maybe we can make small changes as an entire family. You, your husband maybe can start walking together in the evenings. She's like, doctor, my husband also is very fat and don't like to walk. I'm like, okay. So I said, okay, I understand it's a very difficult situation. I said, how about we get the gland doctor involved, because then we have support group for obesity. He can see peers where they can exercise together, because teenagers tend to listen to their peers better. And then she's like, okay. Then I had to go on to complications of obesity, like snoring, OSAS and hypertension. I said, right now the blood pressure is normal, but it would not remain that way if he continues this sedentary lifestyle. And at the end of it, the mother was okay. She was not angry anymore. And yeah, I think I got good feedback for this station and full mark also. So yes, I think that's
okay.
about it.
Anyone has any question to Dr. Vilashini? Because we will start now, Dr. Shinash. Dr. Nada, then waiting. Yeah, please, you can ask. Open your mic. Yes.
First of all, congratulations, Dr. Vilashini. And I really want to know this exact task in this station, last communication, that GP diagnosed type 2 diabetes. So what was the exact task?
The GP has diagnosed that type 2 diabetes. Talk to the mother. So I was also confused at that point. Is this really type 2 or is just impaired fasting? I decided to go with impaired fasting because they only gave me one reading, and I think it's a bit unfair to diagnose with just one reading. And so, but I did mention that after all these modifications, we will have to repeat the bloods and see whether there's any improvement. If there's not, if this is persistent, then we may need to consider diabetic medications. But at that point, I didn't diagnose diabetes mellitus.
Thank you.
I think in the chat, there are some other questions. Whom you are talking with? Child, mother, or?
Mother. I was talking to mother. Angry mother.
Okay. So dear candidates, any more question? Because we will have now our Dr. Shinash. Yeah, previous station, Dr. Vilashini, it was child, right?
Child. A role player, yes.
Okay, so we will start with Dr. Shinash now, then Dr. Nada. Okay, thank you, Dr. Vilashini, and all the best for your future journey, inshallah. You will do good.
Thank you.
And tell about the materials you used, how you studied.
Okay, so I studied for 6 months, which was very was a very long period. And the study materials, I think I already mentioned just now. It was Mark, BT, Rebecca, Malaysian book, and really important topics was Wayne Harris, but mostly it was Dr. Tamanna. And yes, that's about it. But I did study every day for 6 months, which was not easy.
And continuous irritation by my mock. Dr. Vilashini mock, Dr. Vilashini mock.
So I used to play your videos even when I'm not actively listening, your videos were always in the background playing somewhere as loud in the loudspeaker. So my husband used to say, I hear Dr. Tamanna's voice more than your own voice. I'm like, yes. You just... So even in the car, when I'm driving back, it's always your voice.
It's very funny. Yeah. Okay. Any more question? Okay. Which station need more stress and time for preparation?
I think this depends. If communication is something that you struggle with, then it's communication. But I feel all of it needed equal attention, because I thought I was ready for cardiovascular station, but turns out I missed the lateral thoracotomy scar. So I'm not sure. It's just very, very stressful at that point.
Yeah. Okay, thank you, dear. We will talk again. And if we need more help from you, we will ask you anytime.
Okay, thank you.
Yeah. Same to you for us. Yeah, Dr. Shinash, can you start your station, please?
Yes, ma'am. Assalamualaikum.
First of all, congratulations. Walaikum
Thank you.
assalam. And thank you for coming.
Thank you, ma'am, for anything for you. No problem. Thank you, first of all, Dr. Tamanna, for all the help. Actually, I already thanked her multiple times, but I don't think it is enough. Just before I start with my stations, just short briefly about when I started, because many people are asking me this question, how much time for preparation? Actually, I think there is no fixed time like that. Everybody can take their own time. But I joined Dr. Tamanna by the end of January. But February was very stressful month for me, so I could not do much in February. So my actual preparation I started by end of February only. And again, it was pushed by Dr. Tamanna only, because she kept bombarding me with her videos. Though I was not asking her videos, but she kept bombarding me and I had to finish those videos. So like Dr. Vilashini was saying, while driving, while walking, while eating, every time this video was on. And because it was long videos, like 3-hour sessions, I had to run it at 1.5 speed in YouTube and finish the videos. Alhamdulillah, I finished the videos, and most of the time, I think if a person is having time and he can sit through the videos and make the notes, I think that is more than sufficient for you to pass the exam, for sure. Apart from that, resources I used the same as Dr. Vilashini said. Apart from that, I used about some books from clinical by Dr. Khidir and development also by Dr. Khidir. That's all. I think this much of resources more than sufficient. But if you can sit through 6 months of Dr. Tamanna's classes, make a note, I think that is more than sufficient. She even took classes for me just before the exam also. Just one day prior to the exam, I think next day my exam was around at morning 9 o'clock, and 1 o'clock I was sitting and listening to Dr. Tamanna's classes. So that's how it went. Regarding the stations per se, one thing is, don't give too much of, just advice from my side, don't give too much of emphasis to writing, because many of us are preoccupied that we have to write. If you can write, well and good. If you cannot write also, it's not going to make a big difference, because the exam nature itself is a very hurried exam. So you are running from here, running from there. So in between, you may have time, you may not have time. So don't give too much of stress to writing, because then the stress is on writing. Just prepare for the next station. And if you have the time, especially if you can just write the templates for the history taking, so that you don't miss anything. And developmental, if you can just write through brief this one, it's fine. Other stations, you don't need to write anything because it will not be helpful. And history station, once you're outside the station, you can write the differential diagnosis just like Dr. Tamanna says. So I started my session with video.
Sorry, your exam is on Saudi Arab, KSA, right?
Yeah, KSA.
KSA. Okay, yeah. Start, please.
So my first station I started with video. The first video was outside. I think the command was, the comment was, it is an 18-month-old child coming with swelling of the left lower limb. So I had a child who was actively playing on the bed. He had obvious swelling on the left lower limb. There was it was a tense swelling. There was redness. So it went with cellulitis actually. When the end of the video, they made him 18-month child. They made him to stand. So he was not willing to stand on one leg. So it was clear it was cellulitis bar septic arthritis. But because I think in video stations, they want us to go through the guidelines. So he emphasized more on septic arthritis versus osteomyelitis. So the station went smoothly, including diagnosis, investigation. It was through and through the guidelines only, nothing else. He did not deviate from anything from there. Once he was thorough with the guideline, I think it's easy station for you to pass.
Okay, so it was osteomyelitis, right, Dr. Shinash?
Osteomyelitis bar septic arthritis. Actually, the swelling was in the lower limb, in the shin area. So it was not particularly joint swelling actually. So I kept three possibilities: septic arthritis, cellulitis, and also this one, osteomyelitis. Because they did not specify, like the video did not focus on joint as such. It is showing complete lower limb. And at the end, he was not able to bear weight. Because he was not able to bear weight, I kept a possibility of septic arthritis and osteomyelitis before cellulitis.
Very good. Okay. Any comment from this video station?
I think he just said well done only. He did not give any other comment.
Very good. Well done. I am also saying well done. What is your next video?
Next video, I think it was common video for Dr. Vilashni also. I don't know if it was the same video. It was 10-year-old girl who has history of fever and respiratory symptoms, already taken one course of amoxicillin with no improvement. And in the video, initially, they started showing the chest movement actually from the back. So there was obvious decreased movement on one side. And then they showed the percussion note, which was showing dull note. Then they showed the auscultation part. Auscultation part in the upper area, there was obvious bronchial breathing. And lower side, there was some decreased air entry. So it was a very clear video, this one, pneumonia with pleural effusion bar empyema. So the discussion again same. It's the guidelines only. The guidelines of pleural effusion. He wanted to go through the guidelines completely, and he went through the guidelines each point, and he had enough time to ask all questions. Because I think 5 minutes is good enough time. So I think for video stations, you have to be thorough with the guidelines.
Okay.
I think he did not give any comment for me this year. It was full marks, so he did not give any comments.
Okay. You can ask any question to Dr. Shinash. Anyone, if you have any question. Okay.
Then
in video station, sorry, in video station, will they go till the management part, or like they'll restrict us to?
No. They have complete. They will take. The thing is, video stations maybe interpretation different, because this one for me, it was I interpreted as pneumonia because I could hear obvious bronchial breathing. Some of them, they did not, they excluded the pneumonia part. They went only for effusion only. But I think most of them got full marks, but they go through and through with the guidelines till the management part.
Achha, okay. Thank you.
If I think if there's a shortage, if you go slow, because these two were, I had prepared well for these two stations. So I was through and thorough with this, so I could go fast till the management. So he did not have to stop anywhere. So he did not ask any questions. Also, whatever I knew, I was telling, and like only management like that, only questions he was asking. He did not cross question me anywhere in these two stations. The next was clinical. So in the Jeddah exam, it's not a round circuit. Actually, it is what do you say? It's like a U-shaped circuit. So from my circuit to the clinical station was itself about 40 seconds, but 40 or around 40 to 50 seconds. So you have to walk till there, then you wait outside. Alhamdulillah, for clinical station, I think it will not matter much, because clinical, you don't have anything outside. But for other stations where you need to read the command, the time, because this time is deducted from the time, because once the bell rings, the time is uniform for everyone. So this logistical concerns are not their concern. So for clinical, I had to go to different area, a little bit different area. So if you are like, for example, if you are going for a developmental or a history station like this, then you will have less time to read through the command. So like 3 minutes, sometimes the commands are long command, like it is about 6 to 7 lines like that. So you have to be fast and you have to keep like, you have to assess very fast. So the time is a bit difficult in this. So clinical station, the first for me was abdomen station. Abdomen station was around a 12-year-old girl who was a little bit thin and short for her age. And she has obvious thalassaemic facies. And she had jaundice. She had hepatomegaly. There was some scar in the hepatic area. Actually, it is like 3 points, three different scars, small, like a pointed scar. Like, but I could. He asked me what is a scar. The rest of the things was all discussion, differentials of hemolytic anemia and what will you do, how you manage everything. At the end, he asked me what is this scar. So though I mentioned the scar, but I was not sure. I said maybe cholecystectomy. He said, what are the other possibilities? Because it was like a laparoscopic scar, 3 scars, but it was exactly in the hepatic area. And I think he deducted 1 mark for me because I could not answer that. Otherwise, he wrote as a well-structured examination, I think as a comment in that. And he gave me 7 marks, I think. 1 mark he deducted from this one.
This scar is for hepatic, what?
I don't know. In the comment he mentioned, I could not understand what he mentioned the comment also actually. That scar is for something.
I will check your comment. I have your comment. Yeah. Next station.
Yes, just before I go to next station, in the clinical station, again, I think the shortage of time is a big factor because it is total 9-minute station. Out of that, 6 minutes examination and 3 minutes discussion. So in this, once you enter, the bell will ring when you're outside. So once you enter the station, that is when the doctor will give command. So this command itself takes about 30 seconds. She will give command, she will ask the name. So, and memorizing the name is a very difficult part if the command is not outside, because she's giving the name once you're inside the station. Already you are stressed. So just be careful when just to pick up what she says, because if you miss again, she has to repeat, and this will take again 30 seconds, which will be deducted from your examination time. So 30 seconds of examination matters a lot during that station. So listen very carefully to the command, what she says. And if you're not sure, you can ask for sure before proceeding. And whenever she's giving command, just along with that, just look at the surroundings also, if you don't, so that you don't miss anything when you start the station.
Dr. Sinhas, this was the splenectomy scar, laparoscopic. You remember?
No, not splenectomy, ma'am. Because there are 2 different cases actually. Some of them got splenectomy scars. This was actually 3 dots on the liver area.
Dot means laparoscopic.
Yeah, I said cholecystectomy, but I don't know what exactly it was, because it was actually in the hepatic area. So I really don't understand. I did not know. Did you understand the comment what he wrote? I did not understand the comment also.
He did not mention scar could be due to splenectomy. This is the command.
Splenectomy, but because the scar was actually in hepatic area, it was nowhere in the spleen area or something.
Yeah, he may be misunderstood. Yeah, you said cholecystectomy, so that is right. Yeah.
Yeah, I don't know. Then that is what I did not, because other part was okay. This is the last question. So with that, I finished the station.
Okay.
The next station was for me CVS station. CVS station was about, I think it was around 10-year-old boy with the command directly do the examination. He had a mid-sternum scar, no other scars. He was not having clubbing, no cyanosis. He was pink. Examination wise, he had ejection systolic murmur in the left second intercostal space, radiating to the back. So it was very obvious pulmonary stenosis murmur. I did, as per the structured examination, I did the examination part. Discussion part, she asked me she did not ask me differential here. She asked me the most probable diagnosis. So I said it could be a corrected TOF with residual PS, which she was okay with. And then the management aspect of this one, TOF, she wanted, initially she asked something about this cyanotic spell. And after that, she did not want to go behind. She wanted to know how you'll manage now. So it's just follow up only, nothing else.
So it was how much old the child was?
10 years, 10 years.
And what is the diagnosis? Only PS or TOF?
TOF, corrected TOF with residual PS.
Okay.
Yeah, because there was a scar, sternotomy scar.
Okay. He asked about spell management, right?
Yeah, textual management. And apart from that, he wanted just now what will you do, which are the teams involved, and all those standard questions only. It was not difficult questions. They did not ask very difficult questions.
Okay, very good. Number 3 station. Anyone has any question? Please, you can ask. Feel free to ask.
Number 3, it was hemiplegic CP for me. This child actually hemiplegic CP around, she was also around 6 to 7 year old girl. She has obvious wasting actually in the left upper limb and left lower limb. And her examination, but she had multiple devices attached. She had hearing aids, she had spectacles, she had specific shoes also, which was kept actually at the side of the bed. So if you don't see properly, you may miss it. Which like it should not. She was sleeping on the bed actually when I saw the patient. And so I had mentioned everything, and I think she was happy about that because when I mentioned the shoes, she said good. So and then I made her like gait limb. It was examination of lower limb actually, gait examination and all those lower limb examination part went smoothly. Then examined the upper limb because I had some time, and the head for any VP shunt. And with that, we started a discussion. Maybe if your examination is good, I think they don't worry too much about discussion. She asked me like what are the causes, so like vitamin, infantile hemiplegia, stroke, and everything. So what are the teams will you involve for this patient? So I mentioned all because she was having hearing aid, this orthotic, everything, all the teams involved. Then finally she said, I said imaging. If not done before, we will do imaging to know the exact thing, exact cause or exact area involved. Then imaging, she wanted to know which one will you choose. So I said I will choose MRI because of this radiation risk. She said if it is acute stroke, which one you want to use? So I said because of the logistical issue, I will use CT. And why do you want to do CT? So that was the last question. So I said whether to differentiate between hemorrhagic and ischemic stroke because management will differ. I think with that I ended the station. That was the last question.
Okay, Dr. Mrigendra is asking that was there any clubbing in TOF corrected patient?
No, there was no clubbing.
No clubbing.
No. This was, I think, corrected in a good, like early correction. Because it's very good.
Asking too many questions, getting too many questions from the examiner. Is it a good indication or a bad indication?
Very good question.
As I told you, if your examination is really structured and you are not, you go through the examination smoothly, I think the questions also go smoothly. Once you stutter there, I think you stutter in the questions also, because I had multiple feedbacks from other, because like Dr. Vilashni said, at the end of the session, you have discussion with the head examiner. So multiple people raised multiple issues, which Alhamdulillah, I did not face during my examination. So I don't know, maybe if it is like, I think if you go through the examinations very thoroughly, I think then they don't bother you too much with the questions. Yeah, the questions are standardized questions which they will ask you, but I think it's on your preparation completely. For clinical stations, I think it is better to be working in a center so that you can practice this, at least not just like the mocks which we give here, because on a live patient, you are surely bound to miss many things in that stress. So if you make it a practice regularly, if you can go like work for 2 to 3 months in any pediatric department, it will be very helpful in the clinical stations.
Thank you very much, sir.
Very good.
Next.
Yeah, thank you, Dr. Sheena. Okay, next, yeah.
Next is I had the last station was the general station. This was Cushing syndrome. This was 16-year-old girl child with Cushing's. Again, she was short statured with obvious, she had round face, she had the buffalo hump, which we call, or interscapular pad of fat. She had purple stripe. Again, because this was 16-year-old girl child, I was not sure whether to check, because this one, the problem with general station is there is no clear structured examination for general station. So
yes,
this one
it depends on your case, like thyroid approach, Cushing approach. So it depends on individual approach. Yeah.
I personally was not very much satisfied with this station because I thought my examination was a bit haphazard, but somehow the examiner did not comment anything. He gave me full
did
mark.
not comment. Yeah, full mark, did not comment anything. So you are actually haphazard.
So actually I checked for all other, he told me, if you want to ask one history from my mother, I will give you permission. You can ask one history from the mother. So only one history, but he says specified.
Very good. One history.
So I asked him about drug intake, if she's on any drug intake. So she said, yeah, she's taking some drugs for the past 6 years. Then after that second question, I was tempted, but I did not ask because examiner gave me only one.
Only one.
I
Yes,
assessed for
the most important question for Cushing, iatrogenic. Yes.
Then I assessed for other because the Cushing assessment itself does not take much time. So I assessed for the weakness also, like modified goers to look for any proximal myopathy. I assessed for test examination also to look for any signs of chronic asthma. I assessed for partial joint examination also, look for any GIA. If for what she's taking steroids, and I mentioned to him also, I examined other aspects to look for any iatrogenic causes what she's taking steroids for. And with that, I finished that station.
Very good. Well done, Dr. Shinash. And I found your comments are very less. I mean, examiners are very happy.
Yes, thank you.
Okay.
The next station after this station, this was for clinical. The next was developmental station. Development station was around 3.5 or 4-year-old child and do fine motor assessment. For us, I think development history were a bit tricky because in developmental history, they gave all negative history because we were asking for anything and everything. It was negative, 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 negative. They did not give any positive history. Finally, I don't know what I asked, some question which was because rest all were negative. And this child mother felt in school, he is not performing like other children. He had mild delay with the speech also. Otherwise, his gross motor were fine. Other domains were social was okay. His only issue was the fine motor.
What was the
Sorry?
command?
Command was fine motor. Do the fine motor assessment.
What was the command? I mean, in the history that this child has what difficulty?
A mother feels he is not like coping up with other children's school. So he's having delay with the fine motor from other children's school. So to do the fine motor assessment.
Okay.
They did not give any clue also in the history, but I don't know. I don't remember the question which I asked. Then mother said he's does not sit in one place. So from there, I thought I could catch up that maybe she's going towards ADHD. So then I asked about ADHD histories, impulsivity, hyperactivity, and then she came up with some positives. Like, yeah, she feels it's difficult to make him sit in one place. In school also, they say he sometimes hits other children. So then came out the questions. Otherwise, she was not coming out with anything. Like I asked, what is the problem? She just said, she does not write or he does not draw like other children. That's all she came up with. She did not say any positives directly. So I had to probe, and then she came up with this question. In that also, then I went for other histories, family history. Father has history of ADHD.
Very important, family history. Yeah.
Family history. So I think history, template wise, it's very important to go through all the templates because sometimes, I was getting a bit anxious at the end because I could not find any cause for this child's delay. And there was 2 delays also. There was some speech delay also. He did not have any characteristics of autism because whenever speech delay and fine motor and social, sometimes we think of autism also. So it was a bit tricky that way. So at the point,
I like to tell you here one point. I was seeing your mark sheet. All your mark sheet is blank. Only 3-4 station is well done. So you are very good at you did very well, Dr. Shinaj. I mean, it's amazing, amazing. All the mark sheet is blank. I mean, no comment.
Yeah, no, this examiner is very happy because I don't know, he was very happy. In this, actually, the problem was assessment. When we came to assessment, after the history, I said most probably it is because of his ADHD because he does not like concentrate. That is why he's not able to cope up. So that was that. And assessment part came. So again, as we asked any devices, and then we started the assessment. They had all the toys. So I picked up all the toys, and then I kept the cube first. So I asked him to make the relevant examination. And then after doing 2 examination, he started throwing the cube. He was running around. So then I had to make him come back. And because examiner was behaving like that. So I had to make him come back. And then I told him, I tried a reward theory, like I will give you some reward if you do this. Then he did the next task. Then I gave him one toy as a reward. And then after that, I went for the next. I did not give him scissors. I told it may be dangerous for him, so I did not give him cutting. I gave him the crayons. He did something with the crayon, and again he was trying to do the same thing, running away. And then again I had to come back, and I will give one more toy. And then by that time, I don't know. I think the examiner was a bit confused a bit, so he stopped my examination early. He said time is over. Though I think there is still time, because in this, as per them, it was 6 minutes what they advised us, and then 3-minute discussion. So anyways, I stopped when he told me to stop. Then the questions were regarding again same. What is the cause of delay, and what is the same thing? Final question actually, because again this one I finished because there was a lot of time for questions. He asked me many questions also, and still there was like 1 minute left for the question. Then he asked me, what else you want to tell? My questions are over. Then I told him regarding the autosomal dominant, some autosomal dominant, I have to look for him. So there are some autosomal dominant conditions, especially with some like neurofibromatosis or tuberous sclerosis. They have a high chance of ADHD. So I have to assess him if he has any of the signs of neurofibromatosis or tuberous sclerosis. And also, if by 6 years it does not improve, then I will start him on medications. And regarding the medications, and then he was very happy. And by that time, the time finished.
Very good. Well done. There is no comment actually. So what was the cause of this delay actually?
ADHD only, ma'am. There was nothing else apart from ADHD, because as per them, he was not sitting in the class. He was running around. He was very difficult to control child. Even in station also, when I was giving him after 2 tasks, then he was restless. Then he was getting up like that.
Okay, I understood. Very good examiner, huh? Okay. Next.
Next question. Next was history for me. Again, in history, we all faced, I think this was general comment from everyone in this scenario. In history station, the history was a little vague question. It was about a 7-year-old girl whose height is at 7th centile. Sorry, 9th centile for this. Mother feels she's short in class. Take history, relevant history from the mother. Now the problem with this case was the height is at 9th centile, so it does not fulfill the criteria for short stature, first of all, for like a pathological short stature. Second thing was, again, when we started to take history, mother was very difficult. I mean, she was saying no, everything was no. And then one positive, she gave diarrhea, like there is diarrhea. Then I asked, what is, like, how much diarrhea? Then she's only twice, I think it is diarrhea, it is not diarrhea. Then again, she started confusing us. Systemic examination was actually nothing. Everything was negative. Except for this diarrhea, she did not give any positive. Though I probed into all possible aspects. I asked about mother's menstrual history also to look for CDGP. But there also she did not remember her own menstrual history. I asked her about her growth pattern, how it was like puberty. She had spurt. She did not remember that. We asked about her husband. She did not know that. She was kept saying no for everything. So actually, by the time I reached the second column, I had a lot of time left with me. So then I slowed down a bit. Again, I was confused now. What? Because there is no cause I can attribute to this. So what? How do I proceed? The session was my question in my mind. Then again, I went again, probe. Because I had a lot of time for the third column, I took family history in a lot of detail. I asked any person's family. Then she came up with one positive history that her sister's child has, I think, inflammatory ulcerative colitis. Or celiac disease. I think celiac disease, not ulcerative colitis. Sorry, celiac disease. Though it was not first degree relative, but again, somehow then the differentials, when asked, I kept the differentials. Now I said still it is, we have to follow the child. She's short for age. And then differentials I kept, one was celiac disease. It could because there is a family history. Then second I kept still could be considered CDGP because mother does not remember. Third I kept as possibility of neglect also because mother does not know anything about the child. She does not know even the diet history. I wanted to ask about nutrition, like 24-hour recall, what she gave today morning, yesterday. That also she did not know, to count the calorie, how much she take. So I kept neglect also as a possibility. In this station, what happened to me was after the history finished, there was some problem in the exam. They had one candidate had some issue. So they stopped the exam for about 10 minutes because the circuit has to go equally for everyone. So they almost stopped the exam for 5 to 10 minutes actually. So it was again difficult for me because after taking history to remember things for 10 minutes because the flow was lost. But alhamdulillah, still examiner was okay. He was considered. He asked me questions regarding this. And the discussion was, he asked me all possibilities. He wanted to ask CDGP also. He asked me a Crohn's or celiac also. The main emphasis was on celiac, the diagnosis and all those management of celiac disease. And with that, that station was over.
Dr. Sinha, some question are in the chat. You can.
Sorry, I will. Yes. Which one was that? Congratulations. Was it real development session or he was? No, I was asking examiner the question, but examiner was behaving. Yeah, examiner was behaving like a child. He was throwing, I mean, not literally like he was running around, but he was throwing the things. He was behaving like, so he was behaving like the child here. Role player. No, role player. Yes, developmental milestones. History is from the role player, but the assessment is with the examiner. And what autism spectrum disease you mean, ASD? No, she did not have any signs of autism spectrum disease. Like he was having good. I asked him about eye contact. He was not having any social delay because autism spectrum social delay is important. So there was no social delay. He had good eye contact. He was having only mild language delay and fine mood. So it is not fitting with autism spectrum.
In video station, what guideline? They are asking something.
Guidelines is the same. The guidelines which Dr. Tamanna sent us, the book from the UK guideline book. From that, the guidelines, you have to read through the entire guideline properly. There are some, I think, about 25 to 30, which are very important. You have to be thorough with them because video station is all about guidelines. If you know the guidelines, you will definitely get full marks.
The list of the important guideline, actually, I posted in my WhatsApp group.
Yes.
So if anyone is not in my WhatsApp group, you can join in my WhatsApp group. At the last of the meeting, I'll give you link. But there are some important guidelines that you must have to read.
What was the age of child? Child was 7 years, 7-year-old child. And as per her, this child was very active child, very happy child. She did not have any issues, so this history was a bit really confusing everyone. And everyone raised this point also with the examiner. And the examiners comment to us, don't worry about history because all the mothers who come to your clinic may not be the same. So they may not give you the ideal history. And many of the people, because I had the time and I kept probing her, whether family history of this, I asked particularly also for celiac or something like that. And then she came up with this. So some of them could not, did not get that history of celiac. So that is why, again, discussion for them was a bit difficult. And then examiner had to take them towards celiac. So basically the discussion for this station was celiac only and some other cause of short stature. And he wanted to know regarding bone age and all those things in the X-ray. Investigation focus was focused on bone age and X-ray and how will you do we want to do growth hormone. So step by step of investigation of short stature, emphasis was on bone age and management was mainly celiac disease only.
Anyone has any question for Dr. Sinha? Dr. Sinha, we finished or left something?
Two communication. That's all. Okay. Two communication run. After this, it was communication station. Communication station. First one was, I think, about a 4-year-old girl with history of recurrent vulvovaginitis. It is a chronic case. And she has been investigated completely and everything is negative, including swabs, everything is negative. Also, she has been socially regarding the social aspect also has been investigated. Nothing. There is no evidence of child abuse. Nothing. The history says everything is clear and discussed with the mother. So again, this was a bit tricky because you had not much to discuss because mother knows everything is clear. But again, Dr. Tamanna had given one leaflet. In that, there was some the last part to the mother, like instructions to prevent recurrent vulvovaginitis, like keep the area clean, dry, and all those support. There are 7-8 points. So we went through the 7-8 points only with the mother. And again, I emphasized her regarding this. So we are happy that she does not have any social problems, like no evidence of child abuse, because that is really concerning when it's recurrent. And then she asked me one question. She goes for swimming regularly. What happens like if there is anything? So again, the same thing. It was if you keep the area wet, and sometimes some of the detergent which is used in clean swimming also may be like harmful. So we have to be clear with that. And she has to keep the area immediately after swimming. She has to change and clean the area, dry emollients, all those things. And though everything was negative, in the end, I gave her red flags also. If there is any signs of her behavior change or anything suggestive of abuse or any infection, any fever, any foul smell, anything, we have to investigate again. And in spite of practicing so many times, I forgot actually to give leaflets in the mother. I gave some website. I told her you can see this, but leaflet I forgot actually. But she did not cut marks for this leaflet, I think, for me. But otherwise, it was fine. The station was fine because this was practiced in one of the stations with Dr. Tamanna actually.
So we get common, right, from our class. Vulvovaginitis is a very
Yeah.
uncommon topic, but we prepared actually. So very good, Dr. Shinash. Very good that you read what I said. Very good.
And that time also, because this one is my mock only, which I gave with Dr. Tamanna. So it was good. So,
Really? It was your mock station?
yeah, with the mock, it might, we gave history, but it was almost same only. History communication does not, yeah, it was okay. So this was okay. And then the last video station for me was, this was a very lengthy video station. This was about, I think, age I don't remember, but this child has bicytopenia, hemoglobin 5, and some thrombocytopenia, and chronic fever, all suggestive leukemia, basically. So here you had to discuss the differentials with the mother and take consent for bone marrow. So this was 2, information giving as well as consent taking. So it was a very lengthy station actually. So we had to compress. So again, I made a diagram, small drawing with this bone marrow and how the production, everything, explained quickly to the mother. Possibilities, yes, we kept possibility of leukemia also, but other viral infections, everything. About 3-4 differentials we gave the mother. And then explained her regarding the bone marrow, that how we'll do local numbing gel and everything, the procedure. And then finally the consent. I think the role player was trained not to waste too much of time, at least in this, because it was a lengthy station. So her questions were brief only. And at the end, she gave consent also when we gave leaflets. And that was it. That's the end of the question. That is the end of the stations. Alhamdulillah, finished.
Yeah. So Dr. Shinash, one is asking, what was your first communication station? Just name and age of the child. What was the topic?
First communication station was vulvovaginitis. It was, age was, I think, 4-year-old girl who was having recurrent vulvovaginitis.
Yeah, and second one was?
Second one was this one, differentials of bicytopenia and consent for bone marrow. Discuss the differential and bone consent, because usually they give only one. Here they gave 2. So it was breaking bad news, explanation, plus consent.
See, so it was 3. So giving information, right? Giving information.
Yeah, giving information.
Sort of
breaking bad
news.
Sort of, yeah,
and
partial. Yeah, and then take consent also.
So very, very, very difficult actually. Three things in one station. Very difficult. Yeah. Well done, Dr. Shinash. Proud of you. Proud of you that I was able to help. Proud of you. Yeah.
Yes, for sure, ma'am. Thank you so much.
Yeah, hi. Regarding leaflets, may I know, like, are we carrying the leaflets, or are we provided with the leaflets?
No, nothing. You just have to tell them the leaflets. Nothing to, like, we are not carrying anything in the exam. Yeah.
Yeah, thank you. Yeah.
Okay, so any other point, dears? And now I will go to Dr. Nada. Dr. Nada, are you here, dear?
Yeah, hi.
Hi, how are you?
Hi, how are you? Fine, thank you.
Okay, any question to Dr. Shinash, or we will go to Dr. Nada now? Okay, I think no question more. Yeah, please. Which station, Dr. Nada, your station?
So I did in UAE in May. So my exam was actually easier than Dr. Vilashni's and Dr. Shinash's exam.
Because you did well, so you
felt no, this is because I was like, oh my God. But the thing is, I'll tell you one thing. Dr. Tamanna helped me actually, not just in the exam. She's helping me in like be a better pediatrician, you know. I'm not very good. I'm not an exam person, you know. I don't do very well in exams, so I get really nervous and I stutter, and this has been a problem since like forever. But I really became a better pediatrician. Actually, I saved lives because of her. So so that's why I want to say thank you so much, so much. Like last call, I think I saved the life because of her. I checked a child that was like her voice was echoing, your voice was echoing in my head. I saw a kid, I was like about to leave the hospital, but then one child looked really ill, so I went back again. I was like, what did Dr. Tamanna say? First thing, you need to talk to them. So I talked to them. He's unconscious, the kid. He does not respond. So then we had to go and resuscitate, and he had a metabolic decompensation after that, and I diagnosed him only with what she said, even though I was not really sure of the diagnosis in the beginning, but then just because of the approach that she's given you, you feel confident and you really manage beautifully. So thank you very much.
Yeah, congratulations to saving someone's life. It means a lot for a doctor life that you saved someone's life. You know how it feels to lose a child. Only the mother knows who lost a child. Only the mother or father knows this feeling. So to save a life is a tremendous feeling. Whole life you will feel grateful that you are a doctor. Yeah, that's very good.
Yeah.
Congratulations. Okay, so
yeah. So the exam, I started with the history session. It was a clear-cut HSP, so Henoction line purpura. I did the approach, the exact approach. It was hematuria. The kid was a boy. Let me tell you how old he was. He was, I think, probably 9-10 years, something like that. Let's see. I think he had, yeah. They didn't mention it in the mark sheet. Anyway, probably 9 years. So he had hematuria. The mother said that only hematuria, nothing else. Small amount, like and with the like mixed with the urine. Then so I went on with asking her about like urinary symptoms, fever. She said nothing. No. Everything is no. Then the systemic examination, everything was no, apart from the rash. So I told her, when you press on it, does it go? So she said, no. I think no, it doesn't. And it only involves like the lower limbs and the body. So I said, nowhere else. And he doesn't have any like bleeding anywhere. So she said no. So I said, he's systemically well, like he's well. He's not tired, not very sick. He said no. And like no otherwise abdominal pain, only, she said, mild. And I said that he's walking. I asked her, she said, yeah, he doesn't have any limbing, nothing. So then I said, so and the mother, the role player herself, she looked really anxious and worried. So like I told her, what's really worrying you? So she said, actually, we have a family history of cancer, in his bladder cancer, in the I think grandpa. So that's why I'm really worried that he might be having the same problem. So I said, really sorry to hear that. And then we continued. The history was okay then after. But then he asked me like typical differential diagnosis. So I said ITP, could be UTI, could be any other vasculitis. So he said, do you think that this could be SLE? I said, I don't think so, because like he's a boy, he's not a girl, and he doesn't have any other, symptoms apart from that rash. So he doesn't have any neurological, I mean, rheumatologic. So it doesn't seem to fit for me. So he said, okay.
Not like non-blanching. SLE rash is not like HSP rash. Yeah.
Yeah, and again, so he said, do you think this could be meningococcal meningitis? And so I said, I also like don't think that this is really, I mean, least of the differential, because he's a well child, and he doesn't have any positive sick contact with symptoms of meningitis, meningococcal meningitis, and he's well. He is looking well. He doesn't have any fever, so that also is a bit far on the differential. So he said, what do you want to do for that kid? I said, listen, if he's having symptoms of abdominal pain, severe abdominal pain, or debilitating pain that he's limbing and all, then I might think of admitting him, or the the hypertension, or he's having urinary, like renal involvement. I might be thinking of admitting him, and then supportive care. So main first things first with the pain management, and I would be very careful with ibuprofen. So he was happy about when I said that. And then he said, okay, what else? I said that if he's having these symptoms, then I might also consider prednisolone. So he said, what are the main indications for prednisolone? So these are like severe abdominal pain.
Very good, Dr. Nada.
Yeah, and the debilitating pain. And
any other question did examiner ask you from this history?
Sorry,
any other question that you feel?
No, that's I think that's about it. these are the questions that he said. The indications for the prednisolone, the admission, the investigations. I told him everything. Like
Understood. Guideline from the guideline.
I told him. Like so he didn't comment and gave me full mark.
Very good. Next.
Okay. So
next station.
So next station was the communication. So the communication was basically was a TB, latent TB. Mother actually, the protocol, he tells you in the paper that the protocol in this hospital that we need to give them isoniazid for 6 months.
Okay.
Because she doesn't have symptoms. There is positive positive history of someone in the family having TB, and the chest X-ray is fine, but the induration in the test is positive. So the protocol is to give isoniazid for 6 months. You need to talk to the mother about that, about the medication. So mom's concerned. So I talked to her, started saying that the kid, your child is. She said she thought that she's had this test that she's had is a vaccine. So she said after the vaccine, then she's had this reaction. So I said that actually, like, I totally appreciate your knowledge, but this is a test that we do to check this this bug that we were thinking she might be having. But because she's not having any symptoms, then we think that this is like the bug is there in her body, but it's sleeping. It's not causing any symptoms. So she said, okay, so why do you want to treat her then for 6 months? So I said, because actually we don't want this to cause symptoms and to be active, and you have seen how bad it is to actually have the disease. So let's hope that she doesn't. And actually, as a matter of fact, we need to be giving her that to just not make this disease active. So she said, so I need to give it for 6 months. I said, yeah. I was at this moment I was thinking that I can tell her that in the guidelines I read that we can give for two medications and for 4 months. But then because it's written in the paper that this is the guideline of the hospital, so I said then we need to follow the guidelines of the hospital. So that's why I told her.
Yes, Dr. Nada, this is a point I like to discuss, that you did not argue with the examiner. You did not argue what is written in the paper. This point many people miss. Yeah.
So I said, "Khalas, they want to give 6 months. Then yeah, she needs to follow the protocol." So I said, "Yeah, then we need to give 6 months." So she said, "I need to give that daily." So also, what I know is that you can give daily or increase the dose for like 2 days, two days in a week, or give it daily. So. Yeah, so I told her, you give daily. So she said, but my daughter, she doesn't like to take pills. So what do I do with this? So I said, listen, I mean, there's always a way that you can convince kids into getting the medicine, and there's reward systems and stuff we can do, and there is also a syrup, so we can so if this is provided in the hospital, then we can talk to our clinical pharmacist and he can provide that for you if she cannot take it. So she said, but what about this medicine, like for 6 months? So this definitely has hazards. So I said, absolutely, no medicine doesn't have hazards, but rest assured that we will be there. So we will be following her, we will be checking her her other organs, mainly the one that's affected is the liver. So don't worry, there will be follow-ups in the clinic for that, and we will be adjusting accordingly. So we will not leave you to take the medicine, and that's it.
Very good.
So that's it. She was happy. But
why we did a Monto test for this child? Why we did latent TB? Why?
She had there was someone who in the family had TB.
Contact with active TB.
Contact, yeah, there was contact. then that's why I told her, like, it's not, yeah, like you saw her, I think grandpa, I told her you saw her grandpa, how it's difficult for him with the symptoms. So she said, yeah, we are suffering. So I said, see, so if you take this medicine, then we might prevent her going into this. So she said, can she go to school? I said, yeah, there's no problem, because she's not infectious, you know. Only that she needs to, you know, get that that chance of having this disease active, out of the way. I did not do the summary and leaflets. I was very, very, very upset. But then, I don't know, obviously they were happy, so they did not deduct anything for this, and they gave me a full mark, all of them.
Get any deduction, yeah, very good.
Which is wow, which is really, I'm lucky. But then after the other communication, then I remembered. So I said, "Khalas, if this is done, this is done." I forgot what to do.
Very good. Yes,
so I totally omitted this. Totally, as if nothing happened.
Very good.
And then the next one I did beautifully. Like you cannot even imagine how good I did. So
very good.
It was really good. One, like the best communication I have done. For like, I think in my whole entire life. So she said she's a mother of two premature kids, 35 weeker, I believe. She had twins. They were, I'm not sure. I think twins. No, one girl. So she was preterm, and she had pneumonia. It mentioned in the paper that they did X-ray. They had respiratory distress, and then encryptations, and then when you did an X-ray, it was with pneumonia. So you need to start them on antibiotics, and they're preterm. So the mother is not really convinced about this. So talk to her. So then when I went in, I asked her, like, why are you against giving them antibiotics? So she said, I have other kids, and they were given antibiotics multiple times, and I think that I'm suffering with them right now just because of this repeated giving of antibiotics. So I said, I'm really, really so sorry to hear that, and I'm really so sorry for your suffering. But I mean, every case is different, actually. Not every child is the same, you know. So I can tell you that in the case of your kid here, she's born before time, and she's prone to bugs, and she also she needs this medicine. I mean, any medicine does have side effects, but I mean, you have to pick depending on the circumstances. So if it's better for her to take the medicine, then that's very good. So she said, I'm still not really convinced. So I said, when it comes to her, when it comes to your kid, actually it's we're dealing with a vital organ, you know. So we're dealing with the lungs. So if it's if you're not giving this medicine, then the lungs will not be working properly. That means that this is a vital organ, and this might affect her, like, significantly, and this might affect her life, and it might go to the heart. This infection might spread and cause her to have infection in the the bloodstream. Like, do you understand? So she said, well, okay, I do, but still I'm really worried about these side effects and stuff. So I said, listen, if you cross a road, are you really sure that no car will hit you? So she said no. So I said, see, so but do not cross the road if you want to go to the other side. She said, no, absolutely no. So I said, there you go. So we are cautious to monitor the side effects, but we need to give the medicine because this is gonna get us the result that we desire, right? She said, yeah, absolutely. But like, this worry that I have is so much. So I said, listen, you have to talk to I think that let's just get the father involved, because in the leaflet, in the paper, they mentioned that the father is not involved, or she did not tell him. So I said, well, let's involve the father. Maybe he has an opinion that we would like to hear. So she said, he's not here, so we can call him, no problem. And you and him, we can just have a meeting, even like a way meeting, and then with the consultant and discuss that. But rest assured, this is like the right decision to do. And I will like even contact the patients that had the same problem as your child and had the medicine in our NICU, in our critical care, and they are now alive and well and happy. So, and I said, and they've like graduated from university, and they're doing very well.
Okay, very good.
So she was very happy. So
You
really
got full mark, right? You got full mark in this.
full mark, yeah. So she was happy, and she said, yeah, absolutely, I will do that. We will do that. So she agreed to give the medicine then.
Okay.
So this was the communication. Then after this was the clinical. So the clinical was, the first thing was the I think cardiovascular. So I think abdominal probably. Cardiovascular was the first one. So cardiovascular was clear-cut VSD. Oh my God, I'm so lucky. Pan-systolic murmur, nothing else. 9-year-old or 10-year-old.
So lucky.
Yeah, oh my God, I loved it. I did beautiful. Yeah, like, خلاص, it's easy. Yani. Very easy, very clear cut, pan-systolic murmur. So he said, what's the differential? Differential in VSD is really difficult. So I said, I don't know, tricuspid regurg, innocent murmur. So he said, do you think this is innocent murmur? I'm like, no, but I mean, what differential? He's a good kid. He doesn't have anything, nothing. So I said, no, it's not actually, it doesn't seem to be, innocent murmur, because it's, I mean, it's like continuous, doesn't change, and it's like clear cut. So I don't think it's innocent. So he said, so what do you do for him? So I told him, like, we need to do chest X-ray and echo. So he said, what do you see in the chest X-ray? So I told him, and then he said, like, okay, and what advice do you give the mother? So I told, and then how do you manage? So I said, if there is heart failure, then we treat heart failure, and we might at a given moment think of operating, but he's old enough, so I think that this is probably gonna close by itself, but it needs follow up. So he said, what complications does it have? So I said the heart failure, I said the Eisenmenger, I said the valvular incompetence, the infective endocarditis. So he was happy, and he put full mark.
Very good.
No, it was very easy, very easy.
Very good.
And then
the luck was very good also. Luck.
Yeah, I'm very lucky. I told you, I am very lucky.
Luck matters, yes.
The other station was, oh my God, you're gonna kill me for this, abdominal. It was clear-cut thalassemia. But let me tell you, when when you're hesitant, when I don't know why you're hesitant, sometimes, like in the exam, it's the stress, the fear, and you feel like this exam is so difficult. It comes from the moon. It doesn't. It's everything that you guys have discussed is very easy. So it's not hard. So whatever you guys find in the examination, just believe in yourself. I mean, you are taught by one of the best people in the world. So don't worry. Believe in yourself. So basically, this was my mistake. When I examined, it was only splenomegaly, only, nothing else. There was no liver. But I was like, and the girl looked like clear-cut thalassemia, So it was very easy. But I thought like, okay, so why does she not have a liver? Why is the liver not enlarged in this case? This is only.
Yeah, the hepatic hematopoiesis actually stopped. So liver you may not get.
I know, but like when you're like, no, could they just bring only isolated splenomegaly? So I was like, but could this be hereditary spherocytosis? Then I said, okay, I'm gonna be diplomatic, and I'm gonna say chronic hemolytic anemia. So I said chronic hemolytic anemia. He was like, no, I want the diagnosis, the exact diagnosis. So I was like, I only felt splenomegaly. So the first things first is hereditary spherocytosis. He wasn't happy when he heard that. So then I said second is that thalassemia, of course. But he wanted to hear, thalassemia first. But then that's about it. So that's why he deducted 3 marks for that. Anyway, but again, I said that this is not good. But again, I moved on, like whatever.
Okay. Next.
So but yeah, it could be only splenomegaly, and when the kid looks like thalassemia, and this is thalassemia. He said that I made up pallor, but actually she was pale. the kid was in fact pale to me, but he said that
sometimes jaundice child looks pale. The color of the jaundice looks like the child is pale.
looks like, yeah, she's pale. So, but that's about it. Then the other station was clinical other. Yeah, other. The other station was actually this was the most difficult one in the exam. We had a kid like an 8-year-old girl, and she looked like a 6-month or a 5-month. You know, she was very, very small with microcephaly, severe failure to thrive, severe contractures. She had, so he said only examine her, like examine generally. So only do general examination. So I looked at her, in the eyes, she didn't have any devices attached. She only had like squint in the eyes. The back didn't have anything. The chest only had the pictus carinatum, pictus excavatum, and she had like the limbs were cold, so she had cold extremities. Otherwise, nothing else. Like only a very, very small child. No obvious dysmorphic features. Like I did not see any obvious clear-cut dysmorphic features. But the funny part is that she was doing like purposeless movements, you know. So this was very peculiar, you know.
Autism?
So we talk to her, she does not, she only says like blah 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 blah, and she smiles, but she does not respond when you talk to her.
It's autism actually. The child is actually
exactly. That's right? This is what I would told him. So could it be Rett? This is what I was
Rett syndrome, yes.
Yeah. So this is what I thought. So because of the purposeless movement, and he mentioned something while I was examining. She's playing with you, or she's happy that you're here, or something like that. So I was like, okay, I was thinking microcephaly, purposeless movements. I don't know nothing but Rett. But then after that, I said like, it could be anything. It could be CP. Could it be? Yeah, it could be. So
CP child also can have autism, no doubt. Can have.
Yeah. So what else? Like CP, but I said like differential of microcephaly. So don't worry if you don't know the exact diagnosis. It doesn't matter. So he only wants a good pediatrician, someone who can just like have like a way of thinking. You know. So microcephaly. What even if you.
Sorry. Wait, someone's mic is open. I have to mute. Yeah, please. Yes.
Yeah, so I was thinking like, even if I don't know anything, I'm gonna just mention the microcephaly things. So what the torch, the cerebral palsy, these things. So he said, how do you wanna investigate that kid? So so I said like, I need to do an MRI. I need to do she could be syndromic, so I need to do like genetic testing. I need to do what MRI, genetic EEG. I said EEG. If she has, abnormal movements, after doing, his full history and physical examination and full developmental exam. So he said, okay, what else? So I said, like, I need to do MDT, like, multidisciplinary team. So he said, and also fully examine the heart and do an echo and do. So he said, do you think the echo or the lungs or the stuff, you've examined them? You've put the stethoscope. Do you think there's a problem there? So I said, no. So he said, okay. So the problem is like only like in the brain. I don't know why he said that, but I thought that, yeah, even a cerebral palsy patient, you need to check the heart, as part of the, the exam and the lungs. But he wasn't interested in, in that. He only was interested in mentioning, the syndrome, So this was it.
What was the age of this child?
She was 8 years, but she, as I said, she looked like 6 months, 5 months.
And congenital hemolytic anemia, what was the age of the child?
The age was like something like 8. I think it's mentioned in my, it's mentioned in the mark sheet. So the age was, the abdominal was 9 years.
9 years, okay. Okay, so shall we proceed to next? Any question?
Then,
Yeah, I had a question. So how
yeah.
did you confirm it is a microcephaly? Anything like parameters are we considered, or just we can say it is a microcephaly have been
I
have
mean,
seen?
listen, it's gross. Like you can, like for an 8-year-old to look like,
Okay, okay.
you know, it's clear cut. You cannot just not.
But you
not
offered,
mention.
right? You offered measurement of head
Oh,
size.
of course, طبعا. I need to plot her. I said, yeah. And if she's syndromic, then if the syndrome needs a special, I mentioned to him, a special.
So
like,
did you plot any growth charts particularly, or you made it?
he did not ask me to do that. Like he did not give me any. If he did, I would have, but he did
But
not.
you measured with the tape, right?
Also,
As a
he
part of
didn't. We did not have a tape in the. Like I looked around, there was no tape. So, but I said
okay.
I need to properly check it and I need to plot it properly. I mentioned that to him.
Aye.
Okay, but it was gross. I mean, you can just not say it. You have to say it. It's really clear cut. Then after this one, I had the hemiplegia. This was a very nice examiner. I liked him. So this was and the girl was also very nice. 16-year-old girl. She wears the veil. She wears the hijab. So that was a bit. I mean, scary for me. Like, how can I do the exposure, especially with all the things that Dr. Tamanna was really very, very cautious. She said that you need to be very cautious with girls about the exposure. So I was really worried. So I had to ask the examiner, like, can I please, just expose the legs? So he said, yeah, you can ask her. Like, please ask her. So I said, can I please do that? So she said, yeah, absolutely. So I did. Then I said, I need to properly also examine the back, but because I cannot expose, so at a later time, then I need to do that. This has to be, I mean, for a proper examination, this has to be done. So he said, like, you can skip that. When you check the gait, it's very clear cut. Like she's had the clear-cut hemiplegic gait. The hand is flexed and the legs like spastic, the circumduction thing gait. And then with the examination, when you do the examination, then with the inspection, I did not I did not get anything. But then when I looked at the table, there was the hammer and a measuring tape. So when I saw the measuring tape, I already told him that we need to do the leg length discrepancy. But then when I said that I did not use the measuring tape, so I looked at her legs again, and I found there is discrepancy between the two legs in terms of, one is bigger, the circumference of the leg itself, like one of them is a bit atrophied than the other. Lesser muscle mass, you can say. So that's why I told him I need to we need to check, we need to check with the with the measuring tape the both diameters of the both leg limbs. So he was happy about this. And you do the Cronus and you do the Pepinski. And then he said, okay, so what were your findings? So I said, then he told, to what are the differential diagnoses? So I said CP, and he asked about the causes, prenatal, antenatal, postnatal, everything. And the multidisciplinary team, like we mentioned every single one of them for him, but I still had time. So he said, listen, she asked you a question, this girl. She said that I want to do weightlifting. What would you tell her? Because she wants her muscles to be better. So she wants to do weightlifting. So actually, Dr. Tamanna, this is a question I did not know the answer for. But I said, I'm not going to say I don't know. I'm going to be diplomatic, which is what I usually do. So I said, okay, well, I wouldn't say no, but actually I would suggest that she does that with her physiotherapy doctor. So with the help of the physiotherapy team, and we have an excellent team, she's okay to proceed with that, but with the guidance of the physiotherapy team, because sometimes when if she does a wrong, thing, movement or thing, then that might cause harm rather than help.
Yeah, that is actually, you can do graded exercise. Not like heavy exercise. There is a chance of muscle injury because the muscles are very taut. So you should not do that. Yeah, you should be graded. Yeah.
Yeah, so I said if I involve them, then this is their call. And at the end of the day, I'm a safe physician. I'm still a safe physician, even though I don't know the answer. This I thought like a very fast thought. I said that this is better than saying I don't know. So he was happy. Then that's it. And then when I revised it, they say that yeah, sometimes weightlifting actually helps, but you need to do it with someone, not with yourself. So this is a correct answer. And then he was happy and he gave me full mark. Then the video station. The video stations I had. Okay, I had the first one was mastoiditis, clear-cut mastoiditis. The kid was probably 6 years, something like that. And they said that he's a sick kid. He's sick, you know. So I told so they asked me, what do you do for him? Well, what examination do you do for him? So I said everything. I totally forgot, like we need to also examine the mass. We like to check if for tenderness, for I said fever. I said the you know, signs of encephalitis.
Lower limb, yeah, mass, yeah.
Yeah, I totally forgot the mass. I don't know why. I don't know how. You just asked me now, how did you do that? I don't know. I don't know why I forgot. But then she prompted me. So I said, yeah, absolutely. I need to check that. I need to check like the tenderness, the mass itself, how hard it is and stuff. So she said, how do you manage them? And don't ask me why. I mentioned in the beginning oral, but then I corrected it. And I said, no, we need to give IV ceftriaxone. But then she already took my first word for it. So she deducted 1 mark for that. And because she prompted that I need to cover with anaerobes. She said, you don't want to cover with anaerobes? Yeah. So I said, oh my God, absolutely. Clinda.
Metronidazole, gentamicin.
Or Clinda. Oh my God, I hated myself for that. But then
just is for toxicity, actually. Clindamycin is not for gram negative.
I mean, yeah.
Yeah.
And that's it. And then yeah, that's about it. But the complications, I said everything. The differential, I said everything for that. But just the fact that I mentioned the oral, then I changed it. She already deducted. She already took my first word for that. So that's about it. The other station also was like a something that's very common. The post varicella, I mean cerebellitis. But so the kid was like playing with Lego, a kid who's like probably 10 years, something like that. And he was playing with Lego, and it was very obvious that he was having some intention tremor, and you know, like tremor all over, you know. And he was like, she was telling him do the, you know, she was examining him basically for the dysdiadochokinesia and for everything. So you mentioned what do you see, and then after that, what do you think? And the rash was also clear, and they put the picture on the rash, so it was very clear that this post varicella. And then he asked me what investigations. He said that this is diagnosed. I don't want you to diagnose this for me. It's diagnosed. I just want to know what investigations you want to do. So I said brain
scan, yeah. CT scan.
Yeah. Oh yeah. So I said brain imaging, like CT and MRI. So I said, so what are you gonna see with the imaging? So I said, like, I didn't know. I didn't know actually. So I said probably. So I said it's an infection. I was thinking like it's an infection. So there's swelling, probably swelling, like the, you know, the edema, the swelling. So I said, okay. So what complications are you worried about?
Convulsion. I'm worried about.
I said that, but he didn't want to hear that. He wanted to hear increased intracranial pressure.
Differential diagnosis of post-cerebellitis is ICSOL. So he wanted to know, is there any cerebellar tumor? That's why you will do the MRI. Is there any cerebellar tumor? Okay.
I told him mass. He wanted to hear the word. I think he wanted to hear the word ICP. This is you know, features. He said you didn't talk about the need to examine for features of ICP.
Oh, okay.
So he wanted. There was something. I knew that there was something that he wanted to hear.
Yeah.
And he said, you did not give the rationale of neuroimaging. Well, that was like, I told him swelling, I told him mass. There was a worry of mass. So he said, what complications are of varicella? So I said pneumonitis, encephalitis. No, but he wanted this ICP. He wanted ICP. And I don't know, because of this repeated prompting, I was like, oh, there is something in medicine that I don't know.
Fixated,
but I mean,
fixated interest.
Yeah. So this is, he wanted ICP, and he's right. I mean, it's important, but I wasn't thinking of this. So that he deducted 1 mark for this. Last station was the development, and I was khalas, leave me alone. Yeah, no. But also because like you know, this is like a station that you get marks, and this is the most bulky station, you know. So I was like, the history was perfect for me. I asked her everything. This is a mom with a kid who is not walking. I think 2 years. She was 2 years, something like 2 years and 2-3 years. How old was she? I can't recall. And the problem was with her walking. She's not happy about her motor development. This is her concern, her main concern. So I told her, okay, so like, how is she? Like, I asked systemic examination, nothing. She didn't have any constipation, she didn't have any fits, nothing. So, but then when we went back to the past medical and the prenatal and natal birth, so she mentioned that after she was born, she was born prematurely, and after she was born 35 weeks, and after she was born, she was kept in the NICU for quite some time because she had breathing problems, and she did not cry like spontaneously. So she had something with the breathing, something with her breathing, or something with her oxygen and stuff. And then after that, also after she went out of the hospital, she had another problem or another attack with this decrease of oxygen, you know. So she had 2 times this thing. So, but she was not on oxygen at home. But then she mentioned, but she was clearly going with cerebral palsy with me, because she was saying like she is scissoring, she is moving like crossing her legs. Oh, when she is, yeah,
it is diplegia, right?
Yeah, it's diplegia. So she's really like moving towards that with me. She said that she does not have any medications, and she said that she had 1 follow-up with the physiotherapy, and she did not like she missed that, you know, and she's not taking any medications, and there are no other doctors that she's following. So I felt that the mother was not really, you know, concerned as she should be. I mean, for a diplegic kid. So when he mentioned what are the differential diagnoses for this kid, yeah, he mentioned something like he wanted me to. This was weird. He wanted me to give her like an age for every single domain. So he told me in speech, how old is she? In from the history. In motor, how old is she?
Okay.
In social, how old is she? And because I'm trained by you, I took like history that could give me the age only, like one question I asked in each and every one of them, and I got in my head I got the age. So I told him the age of every single one of them, because I had only one question that was guided me for that. But that was a question I did not expect. But then he said, okay, what are your differential diagnoses? So I said the main one is CP, but this child needs also hearing assessment and vision assessment. This was not done, and I think that the mother is not stimulating her properly. She's not going to the nursery, so this could be one other thing. And there is some sort of, I feel like, neglect. He did not like me saying neglect. I don't know why, even though I felt like this mother really is not, following. She's not following, and she doesn't have any medications and stuff. And for a diplegic, I mean, she should be doing better. But he did not like this. He wasn't happy about this. But then after the examination, I was very in a rush, so I did not do the 4D SP wiper. So he was, so he prompted me with this. He said, you don't want to see anything in the kid? So I said, absolutely, I need to check for this morphism. I need to do the, the head circumference, the hair, height, weight. So for this, he deducted 1 mark for prompting me to do the, for DSP. But then the fine motor, I did beautifully. Like I did everything about that. And that was it. He asked me a little bit about cerebral palsy, what occupational therapy they do, what do they do, what the developmental pediatrician does, and all of these things you have told us. And investigations, I told him, he was happy that I told him EEG. And that I told him that this could be, I mean, the CP with the hemorrhagic, this intracranial hemorrhage, the PVL, the periventricular leukomalacia. He was happy to hear periventricular leukomalacia. He said, "This is what I want to hear in a preterm. This is the term I want to hear: preventricular leukomalacia." Yeah, and that's about it. This is my exam. Hello. Yeah, for the SP is the dysmorphism, the dimensions, disease, the dimensions, the devices, and the stress, and S is the surrounding, and P is the puberty. So I did not mention, you're supposed to, when you enter, you're supposed to say them. You're not supposed to go directly in the fine motor. So he mentioned for me that you went right into the fine motor. You're supposed to mention before the SP, and I prompted you, like he said, I prompted you. So that's why for prompting, he removed one more.
Any question to Dr. Actually, we are at the last part of our meeting. We have another candidate, who is Dr. Athira. But Dr. Athira is in duty, and they are actually long time we are doing. I have also some class now. I have to go to a class. So guys, I think we will stop now today, and Dr. Athira is with us. Dr. Athira, congratulations for passing the exam. Dr. Athira, are you here? I think she is in duty. She messaged me, Madam, I am in duty. So we will have another session with our June candidate when they pass. Our June candidate has given 17 candidates have given exam in UK. So they will pass, and inshallah, we will have another meeting. Okay, and any question for Dr. Nada, Dr. Shinash, anyone? We finished actually our meeting today. And congratulations once again, Dr. Nada, Dr. Shinash, Dr. Athira, Dr. Vilashini, for your future. And I wish you all the best. Inshallah, you will do very good in successful life as a pediatrician. And hopefully I will meet you in UK soon. Yeah. So yeah, if anyone has any question, please, you can ask me. You can open your mic. You can ask me. I am here. You can ask me.
Hello, Dr. Tamanna, Dr. Suhail here. Suhail Ashraf. Can you hear me?
Yes, doctor.
Yeah. So just want to know that it was a wonderful session you have conducted, yes, and I am attending for the first time. Just want to know that from where can we have these guideline books? This is new thing to me. I was just thinking that Arabica and these your session would be enough. Do we need to read these guideline books as well?
Yes, guidelines are very important actually. As they say that without guideline, you can't pass any exam. Okay, any exam, any clinical exam, without guideline, you can't pass. And this is my phone number, mobile number. I'm giving you on your chat. Message me, because I am now actually going some class. So message me. I will add you in my group, and then we will give you the guidelines. Okay. This is my number. Yeah, this is my number for WhatsApp. Okay.
Thank you very much, Tamanna.
Thank you very much. Thank you very much. Yeah.
Ma'am, I
Dr.
just wanted
Athira
to
is.
know,
Yeah.
ma'am, what books were read by Dr. Shinash actually once?
Yeah, Dr. Shinash said he read the books as Mark Beatty. He read Khidir books. Okay, these are the books he read. And Dr. Vilashini read Malaysian book. All right. Anyone has any question?
Thank you very much.
Thank you very much for joining. And my number is given here. You can contact me for the upcoming courses, or if you need any help, any assistance, we have groups, free groups, we can help you. And I have a course just started 3rd of June. So yeah, we can discuss if you want to join. And wish you all the best, actually. Join or not join, all the best for every one of you who are giving exam. Okay. And any query, I have a Facebook group that is very active group. You can ask in the group if you have any query related to MRCPCH. Thank you guys for joining. See you inshallah in the next class with some more success story. Thank you very much, Dr. Thank you, Dr. Athira. We could not make you today, Dr. Athira, because you were duty. I am also busy.
Yeah,
So
yes, ma'am. But I think Dr. Nada and I sat on the same day and we almost have the same stations. Yeah.
Okay, okay. I have another class at 11. So I am just going now. I'm in the car. I'm in the car. I'm going
Okay, ma'am.
outside.
Thank you so much.
Yeah, thank you and congratulations for passing. Okay, all
Thank
the
you, ma'am.
best.
Thank you.
All the
Thanks.
best. Thank you. Bye. Bye. Everyone, assalamu alaikum.